Good morning, everybody. My name is Nadeeja Najeeb, and I'm a junior resident in the Department of Emergency Medicine, Amala Institute of Medical Sciences. Today, I'm going to present a case titled The Unfortunate Fall. It is a case of a penetrating neck injury. A 13-year-old boy was brought to emergency medicine department, sustaining a penetrating injury to his neck following a road traffic accident. On examination, the child was drowsy, responding to verbal stimuli, and complaining of pain in his neck. Primary assessment, airway. Airway was threatened. There was hoarseness of voice. Pooling of secretions in the oral cavity was noted. Bubbling of air through the penetrated wound was seen. Cervical spine was tender. In view of threatened airway, rapid sequence intubation was planned and primary assessment was continued. Breathing, respiratory rate was 20 per minute, saturation being 96% on room air. Air entry was bilaterally equal. Trachea was central. Mild subcutaneous emphysema was seen on the left side of neck. Circulation, pulse rate 110 per minute, BP 100 over 70 mm mercury, capillary refilling time was less than 2 seconds, S1 S2 heard, no active bleeding, no distended neck vein seen. Disability, GCS E3 V4 M6, pupils equal and reactive to light bilaterally, no focal neurological deficits. Exposure, temperature was 98.6 degree Fahrenheit, no spinal deformity or tenderness seen. Primary adjuncts, ECG showed sinus tachycardia, blood gas analysis was within normal limits. A NEFAST was done which showed no features of free fluid in the abdomen. No features suggestive of cardiac tamponade was noted. Normal lung sliding in both lungs were seen. No history of any allergy. No history of regular medications. No significant past medical or surgical history. Last meal was taken 4 hours back. History of presenting illness. A 13-year-old male was brought to ED with alleged history of fall from bicycle into a sewage canal. He sustained a penetrating injury to the left upper side of his neck with a wooden stick. He complains of difficulty in talking, difficulty in swallowing, and pain in his neck. No loss of consciousness, no seizures, no vomiting, no breathing difficulty, no active bleeding from the wound. Moving on to the secondary assessment. General examination, no pallor, no icterus, no cyanosis, no clubbing or edema. Systemic examination. Head and neck examination showed a penetrating wound measuring 4 into 2 cm in the left zone 2 of neck, 2 cm inferior to the left angle of mandible. The foreign body was directed to the right ear of the patient. There was bubbling of air through the wound. No active bleeding, no stridor, no expansile or pulsatile hematoma, no thrill or bruit. Cardiovascular examination. All peripheral pulses were felt equally bilaterally. No radio-radial delay, no carotid bruit. S1 S2 heard, no murmurs, no added sounds. Respiratory system. Air entry was bilaterally equal. Normal vesicular breath sounds. Chest compression test was negative. Abdominal examination. Abdomen was soft, non-tender, bowel sounds were heard. Pelvic compression test was negative. CNS examination. GCS was E3 V4 M6. Pupils equal and reactive to light bilaterally. Moving all 4 limbs. No focal neurological deficits. Musculoskeletal system. No long bone tenderness or deformity noted. Professional diagnosis. Penetrating injury in zone 2 of neck with suspected laryngotracheal injury. Immediate management. Airway was secured as per rapid sequence intubation technique. IV fluids and IV analgesia was provided. Surgical team was informed immediately. Exploration under local anesthesia was done. Depth of the wound was found to be more than 4 cm and platysma was violated. Once the child was stabilized, after discussing with the surgical team, it was decided to take a plain CT head and neck along with a CT angiography of carotids. In this CT, you can see that the foreign body is approaching up to the base of the tongue and is compressing the esophagus. You can also note the mild subcutaneous emphysema. The foreign body is compressing the esophagus and trachea, sparing both the carotids. Definitive management was done, surgical exploration and removal of the foreign body under general anesthesia. A 6 cm part was removed. Now moving on to the most important part of this presentation, what is the relevance of such cases in emergency medicine department? We all know that human neck is a very complex anatomic area comprising of vital structures of multiple organ systems. Even though penetrating neck injuries are a rare mode of injury, their high mortality rate, that is up to 10%, demands for a more focused approach to such cases. These patients might harbor insidious injuries with high morbidity and mortality if not managed promptly. In such cases, a careful and structured physical examination is highly sensitive in detecting clinically relevant aerodigestive and neurovascular injuries. In case of penetrating neck trauma, the most fatal causes are that of a vascular injury. The vascular injury, if uncontrolled, can be attempted with a pressure compression or a Foley's catheter balloon tamponade method until definitive treatment is done. Zonal and facial assessment of the external wound will help us to assess injuries in the deeper structures. The neck is divided into 3 zones, zone 1, 2 and 3. Both zone 1 and 3 are difficult for surgical and vascular intervention and are subjected for further evaluation and investigations. If the platysma is not violated, it is very unlikely for a foreign body or a wound to produce life-threatening problems. Nowadays, the zonal approach is no longer being used. It is a modern no-zone approach which is being used now. The key to this approach is to find the presence of hard and soft signs of injury. If the patient is having hard signs of injury along with hemodynamic instability, the patient should undergo emergent surgical exploration and repair. If it is the other way around, that is soft signs and hemodynamic stable patient, he can be subjected to further evaluation with multi-detector CT angiography, esophagoscopy and bronchoscopy and so on. In this case, even though the patient was having hard signs of injury, once the patient was stabilized, he was subjected to CT angiography and definitive management with surgical exploration and repair was done. Thank you.